We currently realize that the second pandemic after COVID-19, the long COVID syndrome, is a disease of the autonomic nervous system. If we neglect research about dysautonomia in the last years, I performed this crash course for the pandemic to give my colleagues the opportunity to understand the specific problems of dysautonomia. For this research, we analyzed the heart rate and heart rate variability generated in the sinus node that represents the. In my first video, I show how to analyze heart rate variability using a 24-hour alter ECG. Now, I will explain how to perform autonomic diagnostic with active standing test using the Biosign device. For our research, we use time domain and frequency analyzers. However, we try to return to the simple heart rate measurement in the 24-hour alter ECG and the active standing test, while mostly represents the success of a therapeutic intervention. Our data clearly indicate the methods that may be used for diagnostic of autonomic dysfunction in children. To diagnose an inappropriate sinus tachycardia, you need a Holter ECG that clearly show the elevated heart rates that are not detectable in the active standing test. On the other side, you cannot diagnose the post-oral orthostatic stress syndrome in the Holter ECG. You need the heart rate increase of more than 35 beats per minute in the active standing test while continuously monitor the heart rate. These are significant data as well in the post-oral orthostatic stress syndrome as in the inappropriate sinus tachycardia, but we found no significant difference in children with vagal syncopes. However, we found significant constitutional features in children with autonomic dysfunction. Most of all, there are high and slim patients who develop post-oral orthostatic stress syndrome, and the inappropriate sinus tachycardia was found in those children who have a higher body mass index. There is a predominance of females in the vagovasal group. The fast Fourier analyzers in the active standing test show clear data in compared to healthy infants. These are the high frequency, low frequency, and very low frequency power in healthy children in the lying and standing position. Those children with a post-oral orthostatic tachycardia show a collapse of the heart rate variability during standing, and those with inappropriate sinus tachycardia show a collapse of heart rate variability during standing as well during lying. And in some patients, there's a changing between post-oral orthostatic tachycardia in one measurement and inappropriate sinus tachycardia in the next measurement. Based upon this pathophysiology, you may understand our therapeutic approach. In the first visit, we give some lifestyle advice like enhance drinking and sodium intake and enhance the body mass index in those patients who have a low body mass index. We further advise alternating showers and low-dose sports, and in some patients, compression garments. At this visit, we confirm additional nutritional supplements with omega-3 fatty acids. In the second visit, if the symptomatic didn't improve, we advise low-dose beta blockers starting with 10 0 milligram propranolol, and some patients we enhance to 20 0 milligrams. If we are not successful, we use ivabradine starting with 0 milligram. At any time, we advise midodrine as a symptomatic treatment that don't improve the pathophysiology, and there are some patients who receive pyridostigmine or sodium infusions. This is our treatment data in children with postural autostatic tachycardia, and you see a significant improvement of the heart rate increase while standing using beta blocker, ivabradine, omega-3 fatty acids in patients with anorexia nervosa together with refeeding. We found no significant effect of midodrine. In detail, you see a lower heart rate while lying and standing using a beta blocker, or a lower heart rate while standing using ivabradine. This is the reason because we use this therapy in patients with high heart rates together with omega-3 fatty acid supplementation. In contrast, you see a higher heart rate while lying, and a lower heart rate while standing using omega-3 fatty acids, and that's the reason that that this is our choice in patients with low heart rate, for example, in patients with anorexia nervosa. These are the specific data and the three therapeutic options, and there is an effect on vagus activity, a significant effect of vagus activity using beta blockers, with a decrease of RMSSD while standing, and a decrease of the stress index that is only insignificantly shown in the other two options. However, using 24-hour Holter ECG analysis, there's the most impressive effect based in children with somatoform disorder using omega-3 fatty acids, with a highly significant impact on heart rates and heart rate variability. This is not shown in children using a beta blocker. There is a prominent effect on heart rates with a low effect on heart rate variability. We see an opposite effect in children after refeeding together with omega-3 fatty acids. There's an increase in heart rate, a significant increase in heart rate, but a decrease in the heart rate increase while standing, and a lower heart rate variability caused by nutritional refeeding. There are data from literature with comparable effects with vitamin D in patients with vitamin D deficiency, and an improvement of heart rate and heart rate variability in adults with cardiomyopathy. I now present three cases. This is a Syrian refugee girl, 16 years old, with a post-traumatic stress disorder with a postural autostatic tachycardia syndrome. You have an improvement of the heart rate increase while standing with propranolol and ivabradine, but there's an overshooting increase of heart rate variability in this girl with propranolol that is not well tolerated, and there's a clear improvement of the autonomic nervous system as well as the clinical symptoms using ivabradine with a complete recovery. These are the data of a 16-year-old girl with inappropriate sinus tachycardia 1 year after COVID-19 infection. There is a high heart rate while lying and standing, and a significant improvement with propranolol and ivabradine. She didn't tolerate ivabradine, of course, the headache and lightheadedness, and there is an improvement of heart rate variability as well as clinical symptoms with propranolol low dose 10-10 0 milligrams. Interestingly, this girl had posterior autostatic tachycardia after COVID-19 mRNA vaccination. She had the improvement with ivabradine over a long time with a lower heart rate increase while standing and improvement of heart rate variability while standing, and she completely recovered with the therapy. However, what stands behind this pathophysiology, there are some data that indicate that autoantibodies against G-coupled receptors are responsive for the posterior autostatic stress syndrome and dysautonomia shown in children with long COVID syndrome, but also in children after mRNA vaccination. There are very high data in children who develop multisystemic inflammation after COVID-19, and perhaps these are the pathophysiology behind dysautonomia. This is the original heart rate monitoring in a boy who had post-infectious fatigue after EB4 infection, and she received 2-gram omega-3 fatty acids for 5 months and completely recovered with this therapy. This is the data of a girl who had chronic Lyme disease with posterior autostatic tachycardia. You see the improvement of the heart rate increase while standing using ivabradine. Very well data are shown in the 3D plot of heart rate variability with low vagus activity in the standing position. This is the second part of this sheet, and it's improvement of heart rate variability after ivabradine. There are very well data about autoimmunity after COVID-19 with many autoantibodies who are shown in these patients, and in this paper the authors conclude that SARS-CoV-2 causes development of new onset IgG autoantibodies in a significant proportion of hospitalized COVID-19 patients, and are positively correlated with immune response to SARS-CoV-2 proteins that may explain similar symptomatics in patients who have natural infection or vaccination. These antibodies are not exclusively shown in patients after SARS-CoV-2 infection or vaccination. We have also found those antibodies in the girl with post-Lyme disease or a further girl with Emery-Dreifuss myopathy, but in further patients who had chronic fatigue syndrome or dizziness, of course, unknown reasons. I now hope that the research of the autonomic nervous system in the last 25 years will help us to improve diagnostic and management of dysautonomia in this pandemic. There are many open questions to understand dysautonomia, and I hope we will find further working therapies to help the patients. But this is the first step to understand dysautonomia and to treat it with the current drugs. Thank you for your attention.